Hello, my name is Matt Strelo from Stanford University, and today we're going to talk about chest pain. We're going to start with a case. Our case today is a 50-year-old male who called an ambulance after having 1 hour of chest discomfort. On initial assessment, we can see that the patient is a distressed man who is alert and able to speak and say his name. His breathing is rapid, but it's clear, and he doesn't appear in distress from difficulty breathing. And when we feel his right radial pulse, we note that it's weak, but not rapid. What immediate interventions then are appropriate in this patient? So our list of immediate interventions that we do on a patient right after seeing them, I would say that this patient should receive oxygen, be placed on the cardiac monitor, and have someone from our team initiate an IV. We divide patients right when we see them into the sick or potentially sick and the not sick. This patient clearly is potentially sick, so we're going to use the emergency medicine approach to this patient, where we do things simultaneously, where we're evaluating the patient, thinking about the potential causes and what we want to do, and initiating actions all at the same time. We receive an initial set of vital signs in this patient, and we note that his heart rate is 75 beats per minute. He's breathing 22, and his blood pressure is a little bit low at 100/70. His oxygen saturation and temperature are normal. We get a rhythm strip off the monitor, and we look at it, and we want to determine if there's any high risk or potentially life-threatening causes of chest pain in this patient based on what we see. So if we look, we can see the rate is anywhere from 60 to 70 beats per minute, and that the QRS complex is narrow. The QRS complexes are evenly spaced and regular, and there are P waves preceding every QRS complex. So if we had to make an estimate, we would say that this patient is in a normal sinus rhythm. We then continue on with our sample history and talking about the symptoms that this patient has. The patient's onset of symptoms was about an hour ago while he was walking, and he describes the discomfort as heaviness or tightness and states that it is not pleuritic, so not worse when he takes a deep breath. It does radiate or go to his left arm and jaw, and it's quite severe at 8 out of 10 on our pain scale. The onset of pain occurred rapidly over 5 minutes, with it being at its worst within 5 minutes. And the patient also endorses some nausea without vomiting and some shortness of breath. There's no dizziness or leg swelling, and the patient doesn't have any palpitations. Out of these symptoms, things that concern me that this could be a cardiac or heart cause of the patient's pain are really the timing and the radiation. So the fact that it onset over 5 minutes and has been present for an hour is definitely concerning that it could be a cardiac cause, such as a heart attack or acute myocardial infarction. Also, the radiation of the pain to the left jaw is a very specific finding for a cardiac cause of chest pain. We have to be careful when using the word pain in obtaining our history. Many patients will deny having pain, but say that they have discomfort, tightness, or pressure. And so if you only use the term pain, you will miss some patients that are suffering from serious causes of chest discomfort. The remainder of our sample history is unremarkable, and the patient says that he does not go to healthcare providers regularly. He doesn't take any medications or have any known past medical history. We do a thorough but rapid exam focusing on the cardiac component, looking at for JVD, feeling the chest wall, listening to the lungs and the heart, all of which appear normal. Looking at his extremities, he does have a trace amount of edema or swelling, and his skin exam shows signs of shock with diaphoresis or sweatiness, and it's a little bit cool to the touch. So these are definitely concerning signs, especially the skin exam signs, and I examine the skin in all my patients, including my chest pain patients, for signs of shock. As we examine this patient, we've been asking questions and looking at his physical exam in a manner which either confirms or refutes specific causes of the patient's symptoms. So we should be thinking about our differential diagnosis as we go. So what are the differential diagnoses, or what are the potential causes of pain in this patient? One problem that I see frequently in training physicians or junior physicians is that they don't think about the entire differential diagnosis when a patient complains of chest pain. They think about the heart and cardiac causes, especially acute myocardial infarction, and they think about the esophagus for whatever reason. They frequently talk about gastroesophageal reflux disease or esophageal spasm. But we want to be more thorough than that, and we can use the anatomy to help us identify potential causes of chest pain by just thinking about what lies in the chest. So to begin, we have the heart, and we could be having acute coronary syndrome or a heart attack. Pericarditis, the sac around the heart, can get inflamed. Myocarditis, the muscle, can be inflamed. Or you can have aortic stenosis or other causes such as mitral regurgitation, which can cause chest pain. We want to think about the great vessels in the vasculature, specifically focusing on the aorta, due to either dissection or potentially a coronary artery dissection. In a traumatic patient, we would want to think about aortic tear as well. The lungs also reside within the chest, and there's a number of conditions that affect the lungs that can cause chest pain in our patient. Things such as pneumonia or infection, COPD, pulmonary embolus or blood clot in the pulmonary vasculature, which can lead to pain within the chest or lungs, and pneumothorax. The musculoskeletal system surrounds the chest, and any problems such as inflammation of the joints, costochondritis, rib fractures, or just plain musculoskeletal strain from overexertion or coughing. The esophagus lies posteriorly in the chest and can mimic cardiac causes very frequently, especially esophageal spasm and gastroesophageal reflux disease. If a patient's been vomiting frequently, esophageal perforation, or if they have a history of esophageal cancer, perforation can be a cause as well. The upper abdomen can have pain that radiates into the chest, so we never want to forget the upper abdomen. And it is a group of organs that lie outside of the chest. But some of the things that we really want to focus on are gallbladder problems such as cholecystitis and pancreas problems such as pancreatitis, which frequently have epigastric discomfort or right upper quadrant discomfort that radiates into the chest. So if we list out our differential diagnosis, we can see that we want to think about these 6 organ systems or 6 organs to help us figure out what our full differential is. And in this patient, he had no upper abdominal tenderness or complaints. So we don't think that he has an acute abdomen that is causing a high-risk condition. However, there are other life-threatening things on this list that lie within the chest that we want to focus on in this patient, such as the heart, vasculature, and lungs. So in summary, when we see our patient with chest pain, we want to take a careful history, evaluating these patients using the term pain, but also using words like discomfort, pressure, or tightness. We want to consider the entire differential diagnosis, using the anatomy to help us develop our differential. And we want to focus on life-threatening causes, and remember worst first in these patients, where we evaluate and treat the things that could potentially kill these patients right away. Thank you.